And this one woman always sticks out to me. She said, "Why would I be showing my vagina on Zoom?" And I'm just like, oh
Why was
my
she busted wide open on Zoom?
right. And so I was like, oh my God, like that completely went over my head that like women may not even find that type of care acceptable, especially when you're just starting. Maybe, and she
Mhm.
said, maybe if I knew my provider and I just needed like a birth control refill, but if I have stuff going on with my kitty
Hoo-ha.
cat, I'm
Right.
not.
Hello, everybody. Welcome to Real Talk, Real Impact. It's your host, Dr. Marissa Robinson, where we are going to center the voices and stories and experiences that matter in public health. So let's dive in. Today, we have Dr. Duroseau, my girl, who is a scientist, clinician, and advocate whose work sits at the intersection of women's health and infectious disease prevention. You know, we understand each other real bad. With over a decade in healthcare, she is dedicated to reimagining sexual and reproductive health systems to better serve diverse and underserved communities, blending clinical expertise with a deep commitment to improving patient outcomes across the lifespan. Beyond academia, Dr. Duroseau partners with industry leaders to ensure equity is embedded in healthcare innovation, bridging cutting edge science with community informed perspectives to drive meaningful real world impact. So, y'all give my girl, Dr. Duroseau, a warm virtual welcome.
Thank
Woo!
you.
How are you
Thank
doing
you.
today?
I am doing well, as well as we can be in these times. So
Correct.
pushing
Correct.
forward.
Yes,
But
so we're
thank you
pushing
for
forward.
having me here. I'm so excited about your podcast and your work, of course.
Of course. And I want the folks to know that we are two girlies that have been in this fight and in this work for many years. And we have kind of been working in tandem with each other, but in different spaces and places. So, can we
Mhm.
start with your story and let the folks know how did you end up doing the work you do today?
Yeah, so getting into research has been like a long journey. So I majored initially in bio and psych in undergrad many moons ago. I'm old. So I during my time in undergrad, I met a wonderful nurse, Pat Zapatak, during my time trying to do some work on campus to be a bridge between students and the health center. And
Hmm.
she just opened the world of possibilities around what nurse practitioners do, the different places we could work. So I continued on with my degree because this was junior year. And then a year later, I went back into nursing school. I worked in emergency medicine. Labor and delivery was my longest stretch as a nurse. And
Hmm.
then I went to grad school. And even my journey through grad school was because of like disparities and inequities that I saw, which kind of
Hmm.
pushed me to get more education. And then I worked in infectious diseases straight out of grad school, largely due to my preceptor who worked in a small HIV family clinic in Bridgeport, Connecticut. And I learned so much from her. And yeah, and so the rest is kind of history. And during a conference presentation, I met my advisor, Dr. Jason Farley, and then some other academics at this conference, and was kind of convinced to pursue the PhD journey and get into research a little bit more to have more impact.
And she's doing just that, y'all. We're going to get into that in just a second. So, can you tell folks about your recent research with Black women in Maryland and their experiences navigating sexual and reproductive health care? And if you want to touch a little bit on PrEP, you can, but we can just start there.
Yeah, so I started my PhD at Johns Hopkins during the height of the pandemic. It was June 2020. So I moved from Connecticut to Baltimore, Maryland, so completely away from family. And I was
Hmm.
working as a nurse practitioner in a Ryan White clinic. I was the sole nurse practitioner running the clinic. And I kept seeing time and time again when Black women, especially, were diagnosed, Their story was, I had no idea how I even became diagnosed. I had
Right.
no idea about prevention. It was like a complete shock to them, no matter where they were in their HIV journey. It could have been 10 years ago, 5 years ago, newly diagnosed. There was just so much mystery around the how, like, this even happened to me. And it was that happened to me conversation that I kept having over and over that made me realize, okay, we have a serious prevention and treatment and education gap when it comes to certain demographics of people. So, with that said, I came into my PhD journey thinking, oh, I've seen it all. I kind of know
Oh,
what the gap is, what the solution needs to be.
yeah,
So,
yeah.
I came in saying, hey, I want to develop a telemedicine, remote options, sexual reproductive health, HIV prevention program for
Mm-hmm.
women.
Mm-hmm.
And yeah, no, through the PhD process, I dug into the literature, kind of realized what some of the gaps were, and
Mm-hmm.
realized we have so much gaps in just even understanding the landscape
Landscape,
of
right,
sexual reproductive health service. So I said, I'm just
right.
going to continue doing the same thing, especially as a clinician. So let me get an understanding of what this
Mm-hmm.
landscape is. So my
Right.
dissertation work was a mixed method study to kind of understand women's utilization of sexual and reproductive health services in Maryland, the acceptability of it,
Mm,
accessibility, trust,
right.
all the different layers as to what services they're using. And when they are using services, do they like it or is it accessible? What's what before I could create or innovate anything.
Mm-hmm.
And in that work, I just, one, found out that many of the women, when I said, would you like sexual reproductive health via telemedicine? And this one woman always sticks out to me. She said, why would I be showing my vagina on Zoom? Why? Oh
Why
my
was she busted wide open on Zoom?
Right. And so I was like, oh my God, like that completely went over my head that like women may not even find that type of care
Ye-
acceptable, especially
Yeah.
when you're just starting. Maybe, and she
Mm-hmm.
said, maybe if I knew my provider and I just needed like a birth control refill, but if I have stuff going on with my kitty
Hoo-ha.
cat. I'm not
Right.
looking to do that on Zoom. And that was when I said, like, yeah, a lot of things we think we know as clinicians and we think we know as people in the work, we don't know unless we're having these conversations with intentionality. And so my
Yes.
dissertation, because it was survey and interviews, I got a lot of data, a lot of insights. We often hear women, Black women in particular, aren't using services. They're hard to reach. In
Mm-hmm.
my work, I found that these women were using services. They were going through great lengths to use services, long wait times, having to advocate for themselves, the amount of fighting they had to do just
It's
for
ridiculous.
basic, it's ridiculous to the point where I don't even tell women to advocate for themselves anymore. I say,
Yeah.
move around. And of course,
Move
that comes with
around.
privilege. If you have insurance
Shop
that's not
around.
locking you in, shop around if possible. And when you can't for other circumstances, escalate and hold these systems accountable.
Accountable. Right.
Right.
And a lot of women don't know that they can get a second opinion, number one. Number two,
Yep.
you should be interviewing your providers, period.
Exactly.
From the
Exactly.
front desk all the way to your checkout process. Who
Right.
was nice, nasty? Who had a good attitude? Who didn't have a good attitude? Did you
Right.
get all your questions answered? Do you need an advocate? Is English your second language? What
Right.
are the interpretation protocols? Do they have an interpreter available? Can you record the conversation? Is there notes that you can get? There's so many things that I think we as practitioners forget to remind patients and clients about the autonomy that they have, but also that they're humans first. And sometimes when you only have a 20-minute window to get through 40 patients of the day, and one person taking that extra 5 minutes is going to cascade into all your other appointments, the provider has the least amount of time with the patients, whereas our nurses, our tech staff, our community health workers, our patient navigators, our front desk staff, our exit staff, they
Right.
have way more customer service and front facing, you know, actual interactions than we do. So
Right.
I think that we're not reinventing the wheel when we say we need to start doing things differently if we want to see different outcomes. And just because we made things accessible digitally doesn't mean that we've solved all of the problems that we have, because we still have a digital divide. We still have a literacy problem. We still have people that don't even have high speed internet, let alone cell phones that have the internet capabilities, which we are
Right.
dealing with in rural areas and even in some low income areas. So a
Right.
one size fits all approach is not going to happen, but we can't move the policy if we don't have the data and the science to back it up. And I'm so glad that your dissertation was one that not only has qualitative data, but also has, that quantitative data, which can look at a larger scale of people, so that when we're talking about, is this statistically significant or is this generalizable? Well, no, because we love to say things are generalizable and like in what context. But when we look at the gaps in care, or we look at the disproportionate rates of those impacted versus those that seek care, remain in care, or are on PrEP, or actually learn about PrEP and get on a PrEP prescription, these are things that are not mutually exclusive. So I'm really glad that you brought, your research to the forefront. And hopefully some folks are looking at this and saying, okay, where do we take this next? Because you kind of
Exactly.
scratched the surface, but there are so many nuanced things when we start talking about political determinants of health, structural
Exactly.
determinants of health, social determinants of health. We could knock people's heads off with just talking about Maryland alone.
Right, exactly. And even I love that you brought up one, the all hands on deck approach, because
Mm-hmm.
Reagan Johnson and I, we wrote a paper about the eight P's instead of the normal six P's. And I had this conversation on another podcast as well about
Mm-hmm.
expanding that framework. And a lot of providers, when they hear that, they're like, listen, we could barely even do the six P's when we do sexual history. How are we going to do the eight P's? And we don't work in isolation as providers.
No.
The MA has a well, she knows all the tea about
Mm-hmm.
everybody. And you would think,
Period. Shout out to all the MAs out there. Shout out to y'all.
I love the MA. Shout out to the MA, shout out to the CNAs, all those
Yes.
support staff.
The
It needs
LPNs,
to,
the CNAs, the
exactly,
MAs, the techs,
exactly.
all y'all make the world go
Even the
round.
front desk staff while people
Yep.
are in the
The
waiting
billing
room.
staff who always have
Exactly.
an attitude. Shout out to y'all.
Right, because they hear the frustrations. They hear what, like the patients when they're calling, trying to reconcile a bill, what's going on in their life. They're telling them
Mm-hmm.
they're about to get evicted. They're about this, they're that. They
Right.
can't afford this bill. That's data points. So
Yep.
it's important to really have this all hands on deck. And also, I love that you mentioned political determinants of health, because that
Yes,
was another
ma'am.
add-on to my dissertation.
Mm-hmm.
Because we're in Maryland, a so-called safe state. But a lot of the women had, because this was during the time of Roe v. Wade being overturned, they had a lot,
Are we tired?
I know, they had a lot of health anxiety and a lot of worry about their sisters in Texas, in the Deep
Mm-hmm.
South, saying, hey, and at any day, the shoe could drop and it's us too. So there was,
Yep.
even though you're in a safe space, you're in a safe state, you're still living in a broader society where
Right.
that is creating anxieties and distrust with the systems.
Exactly. And even if you're in a sanctuary state, or a state that is more progressive or has other modalities that folks can access, the equal the equality across the board is not the same. And when we
Right.
get into the equity piece, that's where we really establish, okay, how do we make this accessible equitably instead of equally? Because just
Exactly.
because equality does not equal equity, and I think we need to go back to civics and learn about the different definitions. Dr. Kamara Jones does a great job at
Yes.
talking about justice, about talking about equality, talking about equity, talking about belonging. And so, if we can kind of put the healthcare sphere, especially in the infectious disease space, and pull all of those things along with us, in addition to making things more equitable for folks who are Black and Brown, yes, we can see a difference, but it's also going to take conversations that we're having with our clinicians, because a
Mhm.
lot of them there's provider bias, even in some med schools, they're being taught Black women or Black people in general have a higher pain tolerance.
Right.
They literally said that on Capitol Hill in
Hmm.
2025.
Yep. It's
That is
insane.
not, it's insane.
Yeah.
So if we're gonna be honest with what we're dealing with here in terms of the landscape and how we can make a difference, we also have to identify some of the nuances that our patients and clients are dealing with, but also meet them where they are. Meet people where they are in their understanding, in their fear or their mistrust, but trying to close those gaps is going to take conversations with, you and I, but also to our folks who are not in public health, to our folks that are not in infectious disease, because I also fear that the burden of infectious diseases and the treatment and the care is put on our ID physicians, our ID staff, and those who are not necessarily in the emergency rooms. And unfortunately, everybody needs to care about infectious diseases because it doesn't know any sex, gender, color, geography. It doesn't matter. Anybody can be something like HIV possible. Anybody can be syphilis possible. Anybody can be gonorrhea possible. You know what I'm saying? Like, we have got to bring these conversations into the American Medical Association and the national academies that talk about these issues that aren't just ID.
Yeah.
Uh,
And it's
infectious
not
disease.
sustainable keeping it in ID anyways. And and
No.
when we talk about like economy and the cost of healthcare, which is very much a capitalistic framework, it
Yeah,
literally, we have higher copays as specialists.
we
So
do.
why are you sending someone to a specialist for a prevention thing? That needs to be handled in primary care,
Primary care.
emergency. It needs to be a
Yep.
no wrong door approach.
Yep.
Why do they need to come to an infectious disease clinic to see someone like me for PrEP? It's ridiculous. And
Mm-hmm.
so we have to support and encourage and help our colleagues along to do
Yeah.
PrEP. And I always tell, my colleague friends, if you're managing brittle diabetics, you could do PrEP. Like that is way more difficult than PrEP
Yeah.
management.
But it's the sexual history and it's the discomfort folks have of talking about sex,
Right,
period.
right.
And that it is only going to get better if we normalize it. So if we talk about men caring about sexual and reproductive health. It's not just for women or persons assigned female at birth and thinking that it only relates to those individuals. Like, we really
Mhm.
have to get to some of the social constructs and bust those things wide open, like old girl didn't want to do on Zoom. We need to bust it wide open in terms of learning about how do we combat some of the things that we have just sustain in society, in medicine, science, and also in public health to make things better. So thank you
Right.
for going off on that tangent, but I think it was really important for our viewers to understand some of the nuances that you have seen, but also what your research has kind of uplifted, and then what your experience has been as a PrEP provider as well. So let's go ahead and talk about what is the tensions that you highlighted in your research when you talked about progressive environments and how Black women still feel deprioritized. And if you can talk about what does real safety and autonomy looks like beyond just policy protections or state labels, because I think that is really where we need to get to in terms of progress.
Yeah, so like I mentioned, you can have quote unquote policy protections in a state like Maryland and still feel unsafe, especially in a 10-minute visit.
Yeah.
How patients are treated matters. How,
Yeah.
even language justice, how we speak to
Mm-hmm.
our patients, the things we say. Just the other day, I heard an ad while listening to a podcast about HIV treatment. It was, I won't name the medication, and it said your doctor will decide which if this HIV treatment is for you. And I thought, like, where is the shared
Mm,
decision making that we talk about? Where
eh,
is the other care teams? There's nurse practitioners, there's, PAs, there's
yeah,
other colleagues involved in caring for patients and helping decide what treatment is for them. What if they don't see a quote unquote doctor? What if their
doctor.
care is a nurse practitioner?
Mm-hmm.
And when you say they will decide, it creates this hierarchy and this authority that is part of the problem, especially when you're talking about people who have a history of distrust because of actual historical harm.
Yeah.
And even the way we talk about distrust, for example, we constantly say mistrust, which mistrust is more so rooted in like feelings, it's a vibe, it's intuition-y,
Yeah.
but distrust is rooted in actual facts and people being able to dig into history, their lived experience, and being able to say, hey, I don't trust this system because of this. That's a very
Mm.
different framing than saying
Yep.
people aren't just vibing with what's going on. So language justice is like a huge part of it.
Hmm.
And you know, in my research, women talking about having to check providers on saying certain things to them, disrespecting them, making assumptions about them because let's say like if they're a single mother, for example, making
Hmm.
assumptions about why that is or who they are as a person. So
Hmm.
there's so much work to be done within the walls of the healthcare system and outside of the walls as well. And I think as clinicians, we're not accessible enough in the public sphere. We
Yeah.
exist within these walls. And I used to have this initiative called Beyond the Clinics, where as clinicians, we engage the public. We go to the churches, we go
Mm.
to the salons, we go to these places to have more like round table type of just chit chat check-ins. So we're not so like untouchable outside of the walls of the healthcare system
Yeah.
because many people don't personally know a clinician
Right.
because of socioeconomic like hierarchies and fragmentation. So that's like parts of it, but it's so many different layers to it. And then if we say we respect people's autonomy, that also is part of allowing them to make decisions. I am a fierce PrEP advocate. I
Yes,
think
you
every
are.
woman should know about PrEP, but I
Hmm.
think women are also able to make the decision whether PrEP is for them or not. And if a
Wow.
patient or a person tells me, I'll pass on this, I have to be able to sit with that, knowing that I armed them with the information and they are able to make that decision. I think sometimes we press and push beyond boundaries that also creates a little bit of distrust because it's like, why are you pressing me so hard when
Right. Like, do
I
you
can
get
calm
paid to push this
down?
prescription?
Right. So we have to think about how we're pushing some of these things because then it becomes it's seen as like some kind of conspiracy or an agenda, and you also don't want that.
Right, right. And it's a fine line between giving someone a toolbox and offering a catalog of options. And
Right.
these are the tools that you have. You can make the decision on what modality you want to use. And that's one of the beauties of having a provider that is educated and understands some of the nuances in infectious disease care. But outside of just that continuum of just sexual and reproductive health in general, that you can make those inroads and it makes sense for somebody. But for someone who is coming in and says, "Hey, I want PrEP," and I mean, I know my HIV status, and we've gone over that, and the provider is like, "Is crickets? What are we doing?" And
Right.
so I think that there's a bigger conversation that is not necessarily happening, and unfortunately, so much of how we react in the US is reactionary. And we could save so many lives and so much money when we focus on prevention, but in a way that makes everybody feel comfortable. And I can understand that someone that's perfectly quote unquote healthy not wanting to take a medication to prevent something, but when you look at what the alternative is of, have living with a chronic condition, then it's like, what is the toss up in terms of the contraindications of all of my other health conditions? What is my medical history? What's my sexual history? What are all these things? And what is the best outcome for my care? Everyone's not able to have that conversation comfortably and accurately. And I think that that's another issue that we have to address with our kind of provider bias and just the gap in knowledge in
Mhm.
general. And I think everybody across the board, when coming into sexual education, everybody should learn about what PrEP is so that at whenever you're exploring, you can have all of the tools in your tool belt, because
Right.
abstinence only conversations are not doing it.
Which we already know, and that's why it's like
We
it's so
know.
to me. And then you made a good point about the lack of education, because I even heard a provider say, "Oh, a patient told me it's either I take a pill now to prevent HIV or take a pill later to treat HIV." And he said, "I told her, that makes sense." And I'm like, well, no, it doesn't, because we
No.
know living with a chronic disease like HIV, yes, it's no longer a death sentence, and we've done a great job with keeping people alive, and they could live a life as long as someone living without HIV. But what we don't talk about is the inflammatory process. We don't
Mm-hmm.
talk about, potential resistance that they may
Yep.
have. We don't talk about the living with the stigma of HIV as
Mm-hmm.
well.
Mm-hmm.
Considerations around like breastfeeding, childbearing, all the things that they can do, but it adds an element of complication. So it is not just as simple as, oh, take a pill for prevention or take a pill for, but you would know that if you had like that education and that information, which I understand we subspecialize, so not everyone's going to have that, but it's important not to lean into misinformation or
Information.
accidentally propagate misinformation as well
Yeah.
as missions.
And they're already dealing with, and we are already dealing with stigma. Stigma is one of the biggest killers that we have in society. And one of the things that is the hardest to address sometimes, especially when you have people that act like, oh, it's not stigma, it's something else. No, the root cause is really stigma. But
Right,
if we want to talk about social drivers and political determinants of health and structural and da 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 da, we can go toe for toe, bar for bar, round for round. But at
right.
the end of the day, stigma and misinformation, disinformation, and some of the social constructs that we have in society and in our own societal norms and in our own communities is really hurting us more than it's helping us. So
Yeah.
thank you for reaching back for that. So, a lot of people talk about equity, and we kind of broached this at the beginning, but it can feel a little bit abstract. It can feel a little tone deaf when we keep preaching equity, equity, equity. So, can you tell our viewers what does, and viewers and listeners, because some folks will be listening to us. So, what does equity actually look like in a real patient interaction or program you've worked on?
Yeah, so I always tell people, because people love to talk about equality, and in a system that's already unfair and
Mhm.
unbalanced, we can't focus on equality.
Mm.
And I get this often focusing on Black women, like, why Black women? Why not all women? Because Black women disproportionately
Look
impacted.
at the data, people. Wake up.
Exactly. And it's funny because people leverage the data when it's rooted in them being anti-Black and propagating misogynoir, but they don't understand it when we have these conversations. So what
Mhm.
equity looks like in a healthcare system would be when care adjusts to the actual individual patient. There's not this one
Yes.
size fits all. It's actually
Yes.
getting to know our patients intimately in
Mhm.
order to know what they need. Even certain things like acknowledging like geo-behavioral realities, where
Yep.
someone lives, who they're
Mhm.
connected to, what resources are actually accessible. And accessibility is not proximity.
Can
Accessibility
we say
is
that again? Accessibility is not proximity.
ex-
Hey, put it
right.
on a t-shirt.
People think it's like, oh, there's a clinic up the street, but that clinic has a history of Henrietta Lacks. They have a history of a family member dying there, of them being poorly treated. That's not accessible. It's
Mhm.
present, is proximal, but it's not accessible. So we have to be real about that as
Yeah.
well, and understanding there isn't a one size fit all. We are living in an era where we have the most prep options available for ones.
Mhm.
But even within that, cisgender women have the least options
Right.
because of like what's available, backed by the science, of course, and the science is getting there. So, like, even within the prep framework, there's not equality. So, when we talk about equity, we really need to think about how we have these conversations and who we're centering in that, and understand that like context matters, and
Yep.
also centering our patients at the end of our clinic encounters, just even saying, what would make this plan actually work for you? I've
Mm,
laid out some of my thoughts. I've laid out your treatment plan, but what is going to make this actually work for you? And they may
right.
tell you, I actually can't take pills, or I actually can't come here every 3 months because I
Hmm.
have work, I have this, I have all these different things going on. You need to ask these questions in order to make sure you're meeting the patients, not only where they're at, but where they want to be met at too.
Hmm. Hmm. I love that. On a personal note, what keeps you, I want to say hopeful, in this environment, but also because you're working so closely with systems that can feel slow to change, and we're seeing funding cuts, we're seeing burnout, we're seeing workforce challenges, we're seeing, we're not seeing it just yet, but we know that things have been dismantled. So what happens when things get dismantled? Things go underreported, and so we don't know what those implications will be in the future. But if you can just, if you want to share, without getting, too weepy, because I know it can be a little bit of a loaded question, but if you can share with our audience, how are you getting through these days?
Yeah, well, one, first and foremost, I'm a woman of faith. So, like, God
Amen.
first, always and foremost, especially in this current climate. I think we're up against not only just like actual warfare, like physical warfare, it's like spiritual warfare. There's just a lot going on. And I think just the egregious nature of the way Black women are treated, it
Mm,
runs deep and it's spiritual because it's literally insane to me.
yeah.
Outside of that, because I know that's not the framework everyone operates within, honestly, Black women like you doing this amazing work and actually creating pathways for women coming up behind us.
Hmm.
And women, to be honest, like Black women get it done regardless. And I also love the fact that Black women are also having the conversation of sitting it out, not
Yeah.
bearing the brunt of the labor of to fix things that we didn't break. So
Yeah.
knowing that women are finding rest and even elements of joy in the chaos
Yeah.
brings me joy and keeps me going. And also knowing that this there's nothing new under the sun. When I think back as a Haitian American woman of what my ancestors had to overcome to even privilege me enough to say I have like a PhD to this day,
Hmm.
it seems like, oh my God, that was insurmountable to them. So
Hmm.
this current climate here, although strained, although a lot, and some days I'm just like, what are we doing? I
Yeah.
just know like Black women are going to get it done. We're resilient. Unfortunately, I don't want to pedestalize resiliency. We've had to be resilient. And because we've had to be resilient, I know we will overcome. And because I know we've been doing this work with less, we can do what needs to be done to survive, and not only just survive, but to thrive. And I know we're focusing on so many different things, but now we have an opportunity to talk about the systems, to
Yeah.
rebuild the systems that were never even meant for us in the first place.
In the
So,
first
although it
place.
sucks they're crumbling, like academia is crumbling, but as someone who just navigated academia, a lot of it needs to crumble, to be honest. It's toxic and it's problematic in so many ways, and it's gate
Hmm.
kept in so many ways. So a lot of
Mm.
things do need to fall in order
Hmm.
for us to rebuild. So,
You better talk
yeah,
about it.
yeah. So looking at it through that lens, it gives me hope for the future.
Hmm.
And, just knowing that Black women are always going to stand in that gap and we're going to do what it do regardless.
Yeah, and whether it's line dancing or it's having podcasts or kikiing and understanding how we can make things happen for our communities. Because when Black women thrive, we bring others with us.
Right.
We always have historically, when Black women have thrived, other women in those environments have also thrived. And I
Yep.
feel like we,
Whole communities.
whole community, child.
Yep.
Okay. And we're not going to all lives matter ourselves to death to get us there.
Nope.
Absolutely not. We
Nope.
still need equitable conversations, diversity, equity, inclusion, accountability, acceptability, and belonging are all still very important. And I want to underscore some of what you said earlier in the fact that we have a calling when you come into the work that we do. Because a lot of times it's not the sexiest thing, it doesn't make the most money.
Nope.
And sometimes we are the invisible workforce. I talk about it all the time. And
Mhm.
until something is broken, there's an emergency, there's an outbreak, someone's passed away, there's deaths, there's illness going on. Sometimes we are never thanked, our flowers are never given. And so I want to take a moment to give you your flowers for
Thank you.
all of the lives that you continue to touch, to shape, to encourage, whether it's for prep, whether it's just to be an awesome Black woman, whether it's just to survive and wake up today. You're doing great work. And for those that are new to who you are and what you will do, I hope that this will help, uplift some of the work that you do and how you fight each and every day for your patients and your clients, but also that at the end of the day, you're a Black woman who's a phenomenal Black woman. And I'm so proud that our paths crossed when they did. And,
Amen.
you always have a friend, a colleague, a sister girl, a confidant, a prep advocate in me. And I'm so proud of what you have been able to achieve. And this is just the beginning, sis. So,
I
we got to
appreciate
buckle
it.
up and get ready because
Literally.
we shaking these systems down and we crumbling them to the ground, but the rebirth and what that looks like on the other end is what gives me excitement and
Yes.
lets me feel like, okay, everything that we're doing is for a purpose. And I don't believe in coincidences. I believe that in divine timing, I believe that everything is supposed to happen in the order in which it's happening. And sometimes we do have to go through loss, grief, and some of those unfortunate circumstances to get to the other side of prosperity and belonging. So I'm super excited that you were able to come on the show. But before we wrap up, can you tell me, where does public health show up in your work and even behind the scenes?
In all the ways. I think like you can't really do the work that I do without having public health central to it. It's
Mm-hmm.
literally the fabric of it. It's in my conversations, it's in my lived experience as a woman of a certain age,
Mm-hmm.
or just even as a woman navigating as well. It's in every fiber in it. And I think even beyond as a clinician, as a scientist, it's in my conversations, in my friendships, just even
Mm-hmm.
having friendships during a loneliness epidemic is
Mm-hmm.
part of public health. The things I talk about with my girlfriends, whether it's dating, whether it's, anxieties around Black femicide, because that's like all
A
the
thing.
rage on social media, the
Right.
levels of madness that people are saying on social media, it's in that.
Ooh.
So, it's in everything. And
Yeah.
because it's in everything, we have to like take it seriously. And it can't just be a talking point or just like, oh, something we do. It's how we live. It's the way we treat the land that we occupy. It's the way we treat each other. It's
Yeah.
literally our existence.
Yeah, I love that. And so, can you tell the people where they can find you? Because we know you're on social media. So, go ahead and shout out how folks can get in touch with you if they want to either follow your platform or follow your work or collaborate with you.
Yeah, so I'm on LinkedIn under my name, Brenice Duroseau. I'm on all the other social media platforms as well. So Instagram, I'm at the NP that cares because I care.
That she
Um,
cares, y'all.
yeah,
Yes.
I'm on Threads, having to read a couple, misogynists to get them together who want to
Mm-hmm.
weaponize stats, but I'm on there if you want to get my spicy side. I'm
Yes.
still on X, a little bit removed. I check in every every now and then just to kind of keep my finger and my attention to the discourse around
Mhm.
PrEP, around prevention, around sexual reproductive health in current times, just how everyday people are talking about it. Because it's one thing to do in a research setting, it's another thing to see it like in real life, tamed.
Yeah.
So yeah, so I'm the NP that cares on all those other platforms as well.
Thank
And
you.
I'm a postdoc at Duke, so you could always find me on the Heat Labs website or on their T32, the Duke University School of Nursing as well.
All right. So thank you so very much, Dr. Duroseau, for coming on the show.
Yeah.
Let's give her a virtual round of
And
applause.
hand clap to you. This is amazing. This is just even the vibe of the podcast, just having just regular, just sisterhood chit chat. I think you're
Yes.
doing an amazing job. This is so needed.
Mhm.
So flowers to you as well for doing this work and continuing to do this work and making space for other Black women like myself to do this work alongside you. So thank you.
Of course, of course. And thank you so much for coming on the Real Talk, Real Impact podcast. Please make sure you like, comment, subscribe, follow the MP that cares, follow Black women, believe Black women, and we'll catch you on the next one. Bye, guys.
Thank you.